Welcome to another installment of the Team Primary Care webinars. Today's webinar is exploring Canada's comprehensive basket of primary care services. My name is Deena Hamza. For this particular Team Primary Care initiative, I am the evaluation lead. Outside of this initiative, I am the Director for Research and Evaluation for Postgraduate Medical Education and an Adjunct Assistant Professor in the Department of Medicine at the University of Alberta. Before diving into our topic, I would like to acknowledge that I am a settler on Treaty 6 territory, which is a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. Now, I have two images here. If you're not familiar with Treaty 6, it includes or encompasses part of Alberta and part of Saskatchewan. And Saskatchewan was the very first province recently, maybe close to a year ago, that decided to implement signage on major highways to identify the treaty. And on these signs, there's a welcome in the respective Indigenous language of that particular treaty, as well as the wording of the treaties in terms of how they would remain valid. And then for Treaty 6, it would remain valid as long as the sun shines, the grass grows, and the rivers flow. And there's also an image here on the sign of the treaty medal. So I thought that would be something interesting to share. And I do realize many of us are joining from across Canada and beyond. So feel free to share in the chat a land acknowledgement or letting us know where you are from. Now, as has become common practice for me, when giving a presentation, I like to involve the audience in some co-learning. So to take the land acknowledgement a step further and our equity, diversity, inclusion approaches a step further. So co-learning number one is this website called IndigenousGuardiansToolkit.ca. If you're not familiar with the Indigenous Guardians or this initiative, it is very much focused on groups coming together to work on being stewards and stewards of the land and the waters and conservation and so on. And so while we are focused on primary care, I think much of what is posted on this particular toolkit on this website could be of benefit to some of the work that we are doing. So on the one hand, it could help us in the way that we conduct evaluation and research. More importantly, I think this chapters 13 to 16 here on the right about ways of building relationships would be really beneficial to the group. Co-learning number two. So in a previous work, I focused extensively on youth interventions. And so I came across this website a while ago, and it's chicagobeyond.org. This is specifically related to research equity. And the title of this guidebook is called Why Am I Always Being Researched? A guidebook for community organizations, researchers, and funders to help us get from insufficient understanding to more authentic truth. And so here's an excerpt here from John Tay. It says, how does it feel to be Black in America? They don't even know you, but they have you, they hate you, or they're scared of you. At the age of 10, they label you a super predator, mama's boy, daddy's, maybe. If he wasn't locked up doing half of 80 years for trying to feed his kid the best way he could, because he's broke and he's Black and he's stuck in the hood. It's just studies to you, but to me it's real. No matter how much I tell you, you will never know how it feels. So our topic today, diving into this phrasing of comprehensive basket of services. Now, prior to seeing the title of this particular webinar, has anyone heard of this term or this phrase, basket of services? Let me know in the chat, and please include the province that you are from. Let's take a moment to put that in the chat. A lot of people saying yes from Ontario. I'm surprised. Yes from Alberta. I'm from Alberta. Basket of services was something new to me. Take a look. Yeah, a lot from Ontario. Yeah, Newfoundland, new for you. Yeah, for me as well. Manitoba has heard of it. Okay. All right. So now before diving into this exploration of the basket of services, I'm going to pass it over to Ivy Oandasan to help situate some of the conversation.
Thanks very much, Deena. And so welcome to everybody here. Good morning, good day, good afternoon to all of you who are here. So this particular topic is the beginning of a conversation. I want to, and I stressed to Deena yesterday, please don't feel like you're the expert in this whole area at this point in time, because I don't think there is an expert in this particular area. And I don't think we have a common understanding related to what are the services that every Canadian should expect to have if they are accessing primary care, a primary care provider. And is it okay that if you go to one primary care provider, that you would receive something different from another primary care provider? If we are moving towards a team-based approach, then the question for me is, as a team, what are the comprehensive services that can be delivered in primary care, in the primary care context, by primary care providers? So as a team, what are we playing? What's the game we're playing? What are the pieces that we should be providing? And with that in mind, we think about how we actually design our healthcare system right now. We design it by including people's roles. We need X number of physicians, X number of nurses, X number of X number of Y, X number. But everybody in those roles who have their own scope of practice and have their own licenses can choose what within their role, what within their profession they choose to practice. And that is within our right as healthcare professionals, right? On the other side, from a patient's perspective, can they actually expect that if they're going to access a primary care team, that if they need mental health services, that there should be a healthcare provider that provides that service within the team? That could be a family physician, that could be a nurse practitioner, that could be a social worker, that could be an occupational therapist, that could be a psychologist. Is it okay that, in fact, when you go to see a primary care provider in a team, that the team can say, I'm not interested in providing any well women care? Is that okay in Canada, as we say that it's a universal health system? Why is it that we haven't actually structured it related to the services that Canadians should expect to receive? And if we were able to create it according to what are the healthcare services, then would we go back and say, who are the healthcare providers that could provide those services? Who has the competencies? Where are the overlapping scopes of practice related to those competencies? And how would we design a team to enable a full complement of what Canadians should expect to receive within a primary care team? I'm a family physician. And as the co-lead for this particular project, some of you may not know, this is Team Primary Care, and I'm one of the co-leads with Ivy Bourgeau. This is a project of the Foundation of Advancing Family Medicine in partnership with the College of Family Physicians of Canada and the Canadian Health Workforce Network, with over 65 organizations across the country. And we are all here to deep standing and ask the questions, and I'm going to say to be disruptors of the system. Why are we structured the way that we are structured today? And we are coming together as a consortium to say we need to train our primary care providers according to a particular scope of services that Canadians should expect. And with that, ensure that the training of our 20 healthcare plus professions that are involved in this project are aligned towards this vision of social accountability for equitable access to care in any community in Canada, that is guided by the principles of truth and reconciliation, of equity, diversity, inclusion, of psychological safety and wellness, and that we do this in an interprofessional way. So what are we doing in an interprofessional way? What are we providing in an interprofessional way? So we asked Deena if she could please take a look at the literature and think about, when we use the term comprehensive primary care, it was choiceful because there is a lot of connotations related to primary care and what's included in primary care. When we use the term comprehensive primary care, we're trying to get a sense of a comprehensive bundle of services that can be provided. And with that, I'm going to pass back to Deena. This is meant to be an interactive session. So we're going to take probably about 20 minutes to actually dialogue, and then we're going to come back. And I'd really love to see some of your thoughts throughout the chat, because this is our session. This is our session to deepen our understanding, to ask the questions, and it is a safe space to challenge each other. We are here together to try and enable a better system, a more inclusive system, and an equitable system for Canadians as they look for equitable access to care in primary care. So Deena, pass back to you.
Thanks, Ivy. So I think it's quite interesting looking in the chat that some people from Ontario had not heard of the basket of services. Some people in Alberta had heard of the basket of services. As I said, being from Alberta, having been involved in primary care for over a decade now, I hadn't heard this phrasing. And so I did a bit of a dive into, what does comprehensive primary care mean? How and where does this phrasing of basket of services come up? So, when published in the Canadian Family Physician in 2018, there's a definition of comprehensive care, which focuses on the type of care family physicians provide, either on their own or with a team, to a defined population of patients across the life cycle in multiple clinical settings, addressing a spectrum of clinical issues. And I would say that this is probably the most common definition that I've seen about comprehensive primary care in my work. There's another definition by the American Academy of Family Physicians. So one that initially was posed in 1980 and updated in 2018. And that's the practice of continuing comprehensive care in the concurrent prevention and management of multiple physical and emotional health problems of a patient over a period of time in relationship to family, life events, and environment. And I found that quite unique, specifically this idea of, relationship to family, life events, and environment. I thought that phrasing was interesting. In 2011, in health policy, this definition actually makes a distinction between comprehensive care, comprehensive services, and whole person care. I thought that was quite unique. So comprehensiveness relates both to scope of services offered and to a whole person clinical approach. Comprehensive services are defined as the provision, either directly or indirectly, of a full range of services to meet most patients' healthcare needs. Whole person care is the extent to which a provider elicits and considers the physical, emotional, and social aspects of a patient's health and considers the community context in their care. And if you're interested in this idea of the distinction between comprehensiveness and whole person care, I really suggest looking into this paper that was published in 2011, because they had certain tools to measure comprehensiveness and whole person care and who would provide that data. So was it the patient that would provide information about comprehensiveness? And, spoiler, one of the outcomes of this particular project is they felt that the authors felt that the patient really could provide content or perceptions related to whole person care, but not so much about comprehensiveness. It was a great paper. More recently published on the Government of South Australia website is that comprehensive care is the coordinated delivery of the total healthcare required or requested by a patient. I thought that phrasing was quite interesting, requested by a patient. This care is aligned with the patient's expressed goals of care and healthcare needs, considers the impact of the patient's health issues on their life and well-being, and is clinically appropriate. So these are just some of the definitions that I came across in looking at comprehensive primary care. And it's no surprise when I dug deep into what are these basket of services? And often when Ivy would say basket of services, I imagined like the shopping basket and all these things that are in it. But the basket of services, the origin of it, the phrasing and the content was developed by the Provincial Coordinating Committee on Community and Academic Health Science Centre Relations in Ontario. And by their own description in their publication, this term basket of services really isn't used that often outside of this group. And the basket of services clearly indicates that there's a requirement of a team. Like when I read these 15 points here of, you know, services that we could expect from a primary care clinic or a primary care setting is quite extensive. So health assessment, clinical evidence-based illness prevention and health promotion, appropriate interventions for episodic illness and injury, primary reproductive care, early detection, initial and ongoing treatment of chronic illness, care for the majority of illnesses with specialists as needed, education and supports of self-care, support for care in hospital, in home, and in long-term care facilities, arrangements for 24/7 response, service coordination and referral, maintenance of comprehensive patient health records, advocacy, primary mental health care, including psychosocial counseling, coordination and access to rehabilitation, and support for the terminally ill. And so as Ivy mentioned earlier, is what are our expectations? Are we expecting all of these basket of services to be available in our primary care setting? Where do we set parameters? Should there be parameters? So those are some of the things that I was thinking of while exploring this phrasing and this idea of the basket of services. And I would like the audience to start thinking of what this kind of sounds like, because as I was reviewing these basket of services, I was like, well, this kind of sounds familiar. Now, and added into this basket of services and this particular document that has this phrasing is the relation to the Starfield principles. And this is very much about, you know, the efficiency, effectiveness, quality of primary care, and that a primary care team, if we are providing care in teams, we are ultimately improving quality, increasing capacity and access, reducing costs. And so the idea behind Dr. Starfield's approach to primary care and measurement to see if, you know, primary care is actually fulfilling these goals is that comprehensive primary care can be sustainable and responsive to the healthcare system. And so the idea is through teams, we can optimize health outcomes for patients and populations. We are then meeting patient and public expectations, which ultimately leads into a sustainable health system. And so those teams are improving quality of care and that they're increasing capacity and assuring access for patients. And ultimately, there is evidence of this reducing total costs of care. So the expected benefits, I mean, better value for the healthcare dollar, as mentioned, improved outcomes for patients, greater autonomy for healthcare providers as they're practicing in a team, and the opportunity to innovate and improve and achieve outcomes, and measurement results that are able to provide greater evidence for investing in and achieving outcomes. Now, let me take a look at the chat. Let me see if anyone, you know, just thinking of this, what does this sound like to you? Let's see here. Does this sound familiar? The basket of services, is it like something else you've seen before? Yes, I see quadruple aim, absolutely, particular, or as it is now, quintuple aim in the more advanced iteration, things related to equity, diversity, inclusion. Yeah, social determinants of health. Anyone else think of a model that this looks similar to? I'll give you the answer. Sounds very, very congruent. Sounds very similar to what we describe in patients' medical home. And so when we think about the core components of patients' medical home, well, we want to enhance access and continuity. We want to identify and manage patient populations. We want to plan and manage care, provide self-care support and community resources, track and coordinate care, and measure and improve performance. So it sounds very familiar to those other principles and models that we are exposed to. So now from the field across Canada, I started a running list of the what of primary care, the how of primary care, and ultimately the who of primary care. And what we see here is it's a very long list of things. Like we have maternity health, child health, inpatient residential. I think many of these things, and in some cases, complex medical conditions, there's the coordination rather than, in this case, chronic disease management as the provision, so that there's the opportunity that those within primary care are providing or coordinating care, which aligns with one of the previous definitions that I shared of comprehensive primary care, that they're either providing this care directly or indirectly. What I found quite interesting in this long list, and I would say some of it is not surprising that this would be a requirement of the community from a primary care provider. But I think one of the ones that I found was quite interesting was a dental clinic. And I don't think I've seen that before in my particular work of having a dental clinic embedded within a primary care setting. So take a look at this list here. Anything here surprising to you, whether it's the coordination of care or particularly the provision of care? And this is by no means an exhaustive list. I'm sure if I continued this over the span of months and years, this list would continue to grow. And of course, the how of primary care. That's something that we often consider as, things like extended hours of care, same day access or urgent care, youth drop-in clinics, access to advice and information that's provided virtually and having multiple modes, so virtually and face-to-face. Networking primary care, patient medical homes with other primary care physicians and nurse practitioners and teams. That's often called like the extended team of who you coordinate with or who is not necessarily responsible for a particular patient panel, but can provide support to patients. Home-based monitoring, team-based care, which is what our team primary care is all about. Coordination of care, continuity of care, culturally safe and appropriate care. We recently had a session with Dr. Pamela Roach from the University of Calgary, and there's this shift away from, particularly when talking about Indigenous group, this shift away from culturally safe care to ethical, using words like brave and ethical care. Linguistically appropriate care, relationship-based longitudinal care, shared care planning, and tailored care. So these are some of the things that I identified across Canada. Now, it's no surprise as I was going through this information and thinking about, wow, this is a lot of potential services that the community needs, and how would that be managed within a primary care clinic? And through Alberta, there's the Integrated Health Neighborhood of the Future. And this was presented in one of the earlier webinars looking at patient medical homes. And if you know me, I'm very, very fond of terms like ecosystems and ecologies of change and so on. And so this particular illustration of the health and conceptualization of the health neighborhood really resonated, in that perhaps what we're trying to build is this health ecosystem. And you have, community members, and then you have your medical home, your health neighborhood, and healthy communities, healthy neighborhood and health communities. And so this was something that just seemed to make sense from the basket of services and, all the different things that people are doing across Canada, that there's this idea of an ecosystem and how to manage that ecosystem and where responsibility would lie in these various aspects. One of the other interesting things that I really liked about this healthy neighborhood component is these little vignettes that I think would be really great from the public standpoint to really understand how comprehensive primary care can be of benefit to them. And so if you're not familiar with this particular report, it's a great report. I would suggest you reach out to Dale. Dale has had a significant influence and input in this particular report. she would likely be able to share that with you or put it in the chat. But this is an excellent way of some of the knowledge mobilization that I came across related to comprehensive primary care specific to the public and what that could mean for them. So in this review of what is comprehensive primary care, of course, there's this idea of team-based care, and team primary care is focused on how we can, swing the pendulum toward more team-based approaches. And looking at some of those definitions, the core definition is that team-based care essentially is provided by 2 or more healthcare professionals. And what's interesting about this conceptualization, or the common conceptualization of team-based care, is that it's almost always the family physician nurse and then the others. And so in some cases, what I found in certain areas of Canada, the other is very vague. And in other settings, in other provinces, the other is a very long, exhaustive, well, I wouldn't say exhaustive, but a very long list of potential professionals that could engage with patients and provide support through this team-based care. And so this gets to the who. So again, this is a running list. Again, if I were to continue reading for months and years, this list would continue to grow. But I mean, many of these individuals here we're quite familiar with. I mean, surprising to me was the dentist again. Not so surprising are things like, having cultural advisors, pharmacists, dietitians. Provincial language services was also something that I found to be unique. Social workers, psychiatrists, geriatricians, lab technicians, and so on. And so perhaps another one may be the lay and peer workers, and just uncovering in more detail how that pans out, particularly maybe on a health literacy and education standpoint. So this was interesting to me, this running list of individuals that could participate in team-based care. And if we're thinking about what the community needs, well, how do all of these professionals, as Ivy mentioned, with potentially overlapping competencies, how do they work together in a team to provide the care to the community? I did come across some interesting resources about team-based care, and this one's specifically Team-Based Care BC. Their definition of team-based care is a model of healthcare delivery where many health professionals work together to support a patient's needs. A key feature is having patients and their care providers be equal partners. So I thought that was quite a nice conceptualization of what team-based primary care could be. I encourage everyone to take a look at this website. I thought it was quite good. It has information for patients or the chosen caregiver, family members, care providers and/or team members, or those who are involved in planning, design, or potentially an improver, working in research, evaluation, continuous quality improvement. Another resource that I thought was quite interesting and nice to see was from the Northwest Territories. And this is taking a look at integrated care teams. And this is specifically a research project. And the way they've conceptualized integrated care teams is that it's team-based care for patients. And that means that healthcare providers work in a close and cooperative way to make sure patients can get the care they need when they need it. Team-based care allows healthcare staff to get to know patients better and provide care that respects Indigenous cultures. And so that's one of the interesting findings in looking at this across Canada, how integrated care teams or team-based care is conceptualized, and quite reflective of the context and the community needs. And so this is a research project, and part of the outcomes that they list in their PDF, it's publicly accessible, is the need to have a primary care setting that's not so much embedded in the medical model. So not a reduction of medical equipment, in the patient rooms, having tea and water available in the sitting rooms, having Indigenous culture-based arts within the waiting room. So quite an interesting project. What they did identify is some of the challenges of coordinating roles and responsibilities of a team, and that's something that we're quite aware of. And I think that there's some work to be done in how we manage those roles and responsibilities, particularly if we're moving away from building a team based on profession to a building a team exclusively about profession, to building a team specific to services that can be provided and competencies. So a reminder, I always have to bring myself to home base, North Star. Where are we going here? What were we planning to do with team primary care? And our goals are to have a collaborative design and integration of health professions, training and practice tools and supports. We need to work together to accomplish this. And an explicit examination of how things fit or do not fit within a system. I am the evaluation lead for team primary care, so I'm quite interested in, system level change. What do we need to cross that bridge? Where are we at? What are our strengths right now? What is working well? And how can we build momentum? And what we don't want to do is have more of the same. And so we don't want to have a siloed design, and our project leads and our project partners are working very hard on their training and design of programs and so on, and tools and integration of tools. We want this to be a collaborative process rather than something that's siloed, so that we can move forward, move into the future of what primary care could potentially look like. And so with that in mind, IVO had suggested that I create a framework, something that we can, as a starting point, that then we could negotiate and discuss and refine. And again, if you're familiar with my way of evaluation, I don't believe that any framework or any approach is static. I think it is dynamic. I think it has to evolve over time. Our contexts change, our priorities change. And so what you see here is just a starting point. This is not written in stone. It's something that can evolve over time. But the idea is, how can we reimagine comprehensive primary care from what we've already seen out in the literature so far? How can we reimagine it, particularly with this idea of, we're familiar with the comprehensive primary care, the basket of services or patient's medical home, what we're trying to accomplish or provide to the community. But what specifically does our community need? So that will differ across contexts. And then here I have scope of practice, but really it's scope of services, as Ivy mentioned. So what can your particular profession provide in terms of services based on your competencies? And who would be your core team? So the core team are the individuals that are responsible for a patient panel. Who would those people be and why? Who would be the extended team and the affiliated staff? Other questions are you providing this service, or do you have the ability to coordinate services? And what would that look like? So what would that look like for the midwifery group versus the pharmacy group versus the individuals that are dietitians or the family physicians? What does that look like? And what are the local and provincial systems that can support your profession's contribution to this reimagined way of providing comprehensive primary care? So one that moves away from, we're going to have a family physician and a nurse and, a social worker provide these services, to perhaps there is a nurse that can provide, for example, mental health services, or the family physician that can do that. And what would the team look like? Are there systems, supports in place? What would need to change within the system to accomplish those goals? So Ivy, this is the summary of what I've come across so far in my search about the basket of services related to comprehensive primary care. I know we have a series of discussion points, but how about I stop sharing here and we start our discussion, and I can pull up those slides with those questions as you see them.
Actually, I'm going to pull up I'll pull up a couple of slides as well for you, Deena. Thanks so much. And again, I'm hoping people recognize that this is the start of the conversation. And as a community, this is part of the work that we need to actually challenge ourselves in coming up with how are we defining comprehensive primary care? How are we designing our training to support comprehensive primary care? And how common is the principles that we use? How common are they in the design of our training and the design of the practice structures that we have in order for us to deliver this kind of care? If it was easy, it would have been done before. This is not easy. And I just want to I just want to give us a reminder of just our project as a whole. And again, we've got 83 people on this particular call. Many of us are part of the project. Many of us are being invited to be part of the project. And I'm just going to ask, Deena, can you actually allow me to share screen? Whoever is doing that, I can actually.
Yes, go ahead, Ivy. You should be able to now.
Perfect. Okay. So let me find this, and we're going here. All right. So I want to remind us, and you're seeing my screen now.
Deena, I think you need to make Ivy a co-host.
Okay. I will do that now, Ivy.
Okay.
Okay. Now you should be good to go.
Okay. Are people able to see my screen or not yet? Nope. Share. Share here and put this up here. Here we go. Now?
Not yet.
Can you see my screen? You cannot see my screen? Yeah. Sorry, folks.
Do you want to send me your slides, Ivy, and I can pull them up?
Let me just try one more time and see while we're waiting.
So I saw here in the chat, IVB, that's a great suggestion about using the term services at the O1 level and O2B scope of practice, and then we don't get into those details about core versus not core, core versus extended in terms of team members. So that's a great suggestion.
Yeah, and just to sort of follow up while Ivy gets her slides up is just to say that you know, core is very political. Core is very setting specific, and so I would, you know, as a team, avoid that, and because I just think that it's so setting and practitioner, or sorry, setting and population specific. But I really like, you know, the layered notion, and then, you know, really having a conversation about what are the services that are provided, and then, you know, picking up on some of my comments earlier, is trying to describe those services in a way that doesn't necessarily conflate practitioners with services. Although, you know, if we have, I mean, you could have oral care rather than dental care, right? You know, so that it talks about it in a bit of an overlapping way.
You know, I just sent you my slides, but I'm thinking about this, Ivy, as when I think one of the challenges is when you think about primary care and it's so big, right? And I think that's what the scope is so broad. How do you limit what that scope is? I think about, you know, people who work in cardiology, or people who work within a discipline like obstetrics and gynecology. It's really defined what those services, like what you can expect. Primary care, we actually really haven't completely understood, like what could those, and they have to be flexible limits, right? Based upon the community need. But I think it gets to, and I'm hoping, Ivy, that in the fall, so we've got a series of different webinars that are coming, but even how do you design your team based upon the needs of community? Right? And where would you need to go? So just right there. Okay, so I just want to remind us where we are, because we're sort of quarter into the project, right? And this notion of comprehensive primary care, we all bought into it in part for this particular project because of the why, and the why because of the crisis in the access to primary care. And yet when you access a primary care provider, you can vary what you're going to receive from a primary care provider. If you access a team, it can vary what you can actually access in the team, depending upon how the team is structured and networked and coordinated. And so the way that governments actually are fixing this problem right now with the access to care is they continue to say, well, you know what, we just produce more. But producing more, and we just saw this with the CARMS match in family medicine, you could increase more seats, but if nobody's going to go into those seats, you're not solving any particular problem. And so the issue is do we work differently? Is teamwork an approach to actually help support the way that we actually can provide primary care services? And if so, then how do we structure that? And then how do we train our healthcare providers in primary care to work in this way. And Romano in 2002 had said that you need to learn how to train them in teams if you're going to actually be able to get them to work in teams. And that's what this project is all about. Next slide. And so just to remind people of the vision is enhanced readiness of a supported primary care workforce that will be created if we advocate to the primary care reform people, right? Ours is the enhanced readiness. That's the training element of it. A supported primary care workforce to deliver more comprehensive services with greater continuity and coordination of care with a whole person orientation. So the training that we're providing to our individual healthcare providers and to our team is aimed at the delivery of comprehensive services with continuity and coordination and care with a whole person orientation. How are we training our learners and our healthcare providers to do this kind of work? Next slide. And so just to reflect upon, and there's animation here, and this is the work that we're doing in Team Primary Care, again, with that vision at the top, that we do have these principles, and we are doing this by actually aligning the comprehensive primary care services and workforce that we're talking about today. We're looking at increasing the number of comprehensive primary care practitioners and how we're actually moving that forward. And we are looking at enhanced flexibility and adaptability of the CPC practitioners in working in teams. We're doing that with the 18+ team training initiatives. And we're hoping that we can actually increase supports for CPC practitioners and working in doing so by giving us some retention planning team resources. But to do that vision, anytime you're trying to bring a coalition together, we have to have a common vision. And we are stronger if we actually have a common vision together. And we need to co-create this. This is something that we designed ourselves. Is it needing to be tweaked? We need your help. Next slide, please. And so here we are. These are the 20+ health professions that are part of the interprofessional collaborative table. So welcome to the new ones that have come before us. Imagine what we can do if we aligned our curricula and helped each other understand what we all do and how we can combine our services to be able to provide a comprehensive basket for primary care providers. What could be possible? Next slide. And while we're doing this with the 20+ healthcare providers, we've got 18 primary care teams now working with us across the country to test how are we training teams, primary care teams with new healthcare providers embedded within their primary care practices to test how can we do this? How can we learn together? And this group will be the team optimization table. This group of 18 will come together and meet together and talk about what are they learning collectively. And the 20+ other healthcare professionals are going to be working together to think about how are they aligning their curriculum towards comprehensive primary care. Next slide. And so our discussion point number 1 is, I'm going to say, what is our collective understanding of comprehensive primary care? Do we have one? Do we need one? And we're going to pause here and open up and say, are there thoughts that are in the chat? Are there opportunities people want to actually speak out in relation to this? And we'll close the slides for a second at this point in time, Deena, and let's see if we have some conversation happening. Is there a need? Are we close? How might we do this collectively? Deena, what do you think?
I think we're close. I think based on the literature, it looks like the support for team-based care is there. I don't think that there's a resistance to that particular approach. I think the challenge is how do you negotiate those roles of professionals, particularly now if we're saying, let's focus on a service orientation, like who can provide these services? And it makes sense in a setting that could potentially have limited healthcare professionals. Like I could think in a limit in an area where there are resource limitations or capacity limitations. It seems that negotiation would be quite simple to accomplish. I will take on these services and you will take on these services. But what do you do in a setting where there's more competition to be able to, profession-wise or providing that service, where there's the overlapping competencies? I think that's where my mind goes to. It's like how it sounds great in theory, it makes sense, but then how do we do it on the ground? And it's that negotiation piece and ensuring people feel valued and that there's equity across the health professions. How do you navigate that?
And I see Isabel there, but I'll make a quick comment and just, I wonder if it is part of the rigidity of the structure, the rigidity of the job descriptions that we have, the rigidity of how you're hired to do X, Y, and Z, without the notion of the adaptability when there are overlapping scopes of practice and competencies. And when there is competition, is there really a competition if we have a shortage of healthcare professionals? I just wonder. So Isabel?
Thank you. I think we're making great headway, and I think we're going to get there, but we need to continue our collective efforts. I would say in dietetics, since we are not represented in all the family health teams, one of the difficulties is to try to fill the gap where there's no dietitian in the team, and understanding referral to maybe dietitians who might be like at a diabetes center, but are not in the family health team, just as an example. But also in general, dietitians will be involved by referral. And I think based on previous studies, if other health professionals are not quite aware of that, then they might see it as an opportunity for nutrition education or counseling, but they don't maybe know the steps to get there. So I know that I think in most family health teams where there are dietitians and some healthcare professionals refer, others will learn to do it, but sometimes it's a gap. So there will be a perceived need, but they don't know that if they don't refer, the dietitians don't get involved with the dossier. And I just came back from a Canadian Nutrition Society conference where we were talking about malnutrition screening in the community. And we were thinking, gee, that would be really awesome if primary care could detect, you know, the health professionals could keep that in their mind as they see their clients, that if some are at risk of malnutrition, that this is flagged, and then we're pushing this forward. And there are some overlapping roles, as you know. A malnutrition screening can be done by various professionals. If the person is malnourished, hopefully there would be a referral. Do we know how it's done in the different settings? Is this being done? Is this a missed opportunity? So I think that if we continue talking about roles and overlapping roles, but how we collaborate to help one another, I guess, in an interdisciplinary way, like you're saying, in comprehensive healthcare, so that it's not, for example, and I'm trying to speak in a non-judgmental way, but here as an example, it's not only the dietitian who's thinking nutrition, it's the nurse, the physician, the social worker, and all the members of the teams that are aware of nutrition would be important to screen for when the clients are consulting and needing care. And then we flag those clients and we have a roadmap of how we support that. And when there's a dietitian in the team, or when there's not, because we know it's even harder with the little time available. So that's just an example, because we are a profession that needs referral by other to be able to do some of our work. Thank you.
And so, Isabel, the common understanding that you're putting forward is there needs to be a common base of understanding about the importance of nutrition, which I would think that everybody is actually talking about that across the professions. But as a dietitian, you are the expert in that area. Have we thought of ourselves as experts in particular specialty areas within primary care that we are referring to each other? And when it is outside the scope, that we actually refer to somebody else? I wonder if that's another way of us thinking about, where is the expertise and when do we need to call upon our other healthcare professionals in the primary care context and begin to actually recognize the value of the distinct competence that people have, and then the overlapping competence. When it is outside of one scope, you need to know who to refer to. When it is out of one scope, you need to know who to refer to. And I'm hoping with the next one that we're going to be talking about this with the next webinar in June, that is where we're going to go with the interprofessional competencies. We're going to talk about how do you teach people about how to do this within a team. Thanks very much. Rachel, nice to see you here.
Yeah, hi, Ivy. Thanks very much. I love this conversation and the discussion. I think it's really important that we provide some guidelines or like guidance on how we're defining or operationalizing comprehensiveness, because even our own definitions of comprehensiveness is informed by our training and our own kind of perspective in our discipline and where we've come from that vantage point. And teams and interprofessional teams provide us with like a much broader ability to define and operationalize what that could potentially look like. But in part, it's also influenced by our previous exposure. So just wanted, to highlight that having interprofessional training in, early training at universities is really, really important, because many providers don't actually have that contact until they're in practice. So that's, really important. And we see such variations across teams. And so providing some guidance, for example, around mental health care, what that could potentially look like will help, when we haven't had that previous exposure.
That's a great point, Rachel. And I think that is the opportunity with the 20 healthcare professionals that are coming together for the first time to talk about what is in common in the primary care context. What are we learning and is it aligned? And where are the differences? And how do we begin to have our healthcare providers, one, be role modeled by primary care healthcare professionals in your fields that have not been recognized necessarily, and we need to optimize who they are and then be able to share that opportunity. So I just think that there's huge opportunity with this project if everybody in those tables begin to dialogue with each other and learn about from and with each other, which is the whole interprofessional language of this of what is interprofessional education. And again, just a plug in for June that we will be having a webinar just on the new competency framework for interprofessional care. Other thoughts? What are you seeing, Deena?
I was just putting in the chat because what I saw here from Doug is about, it relates to something that I had seen online while looking through these different resources. And I don't know if anyone else is, maybe I'm just the only one that doesn't know about this, but there's the North American Observatory on Health Systems and Policies, and they have a series of rapid reviews. And what I can do is actually pull up just very quickly on the screen here some of the work that they have. And so I was just writing to Doug and letting him know that he was suggesting, is there a way to co-locate services for patients? And so I was thinking about this one rapid review that I came across, which was called Care Closer to Home. I think it's from 2019. But it's on this list. I won't go through all of it. A couple of other rapid reviews, Ivy, that I think are really great to take a look at is delivering primary care in non-traditional healthcare settings. This was a really great one. Improving access to high quality team-based primary care in rural, remote Northern Canada. And it does talk about 3 different models. One about is the community health centers, about a nurse practitioner-led clinic, and a nurse integrated. So one was nurse practitioner led, I think, was on about Ontario, an Ontario case study. Nurse integrated was from Saskatchewan, and I think the community health center was also from Ontario. And another thing that was interesting to Ivy about clinical services and the provision of clinical services is this other rapid review that I came across, which is primary care governance and financing and how that plays a role. So just looking through the chat and seeing what people were talking about, this reminded me of this component that I came across.
Well, thanks so much, Deena. And we're at time in many ways here. And again, this is the conversation starter. And I saw IVB put into the chat. If there's people who are interested in exploring this further, it is a need for us in terms of our community of kind of understanding, because then we translate it back to our IP collaborative table. And what we're learning about how we put teams into place is going to be practiced with the team optimization table with the 18 plus teams that are going to be doing this. And we will learn from that. Again, to help you understand that we're going to move together in these webinars. So you've seen already the principles. We've talked about truth and reconciliation, the amazing one that's there. If you haven't seen it from last week, please do. Understanding what patient's medical home is. We're going to talk about the principle of equity, diversity, inclusion, the notion of psychological safety. But we're also going to go deeper in the next few webinars. It is going to be talking about, okay, so this is team-based comprehensive care. What do we mean? What are the competencies that you require? How do we negotiate? How do we negotiate? What is a culture of team that we need? And how might you actually design a primary care team based upon the community's practice, the community's makeup? And we'll welcome you to share if there's other ideas that you have. With that, I'm hoping that you found this provocative, opening up the door. Remember, we are the education side of team primary care. The conversations we need to have are with the other practice side folks in order for us to align and work together in order to move team-based primary care as a reality. Our side is training, but we need the practice side in order for our learners who are going to be trained by us to have the teams to be working within. And our work will be catalyzing for that work as well. So thank you so much. I'm glad that we had this time together, and we'll look forward to seeing you in your own smaller groups, the webinars that are coming in June, July, and August. And please use the social media so that we can actually move forward in connecting more people who are interested in this area with us. Thanks so much, everybody. Goodbye.